Hello, please take a seat. We are ready to start. Thank you to all to be here. This is a great session. We will speak about indirect annuloplasty for secondary mitral regurgitation in heart failure patients. We have several speakers, and we will understand well how to use these new technologies, technology in patients with heart failure. I don't take time anymore, and we go directly to the next presentation because I think it's much important to have the discussion in heart failure. And we move immediately to the first presentation, that is the EMPOWER trial, a landmark in the evolving treatment of heart failure. Vlasidis Ninios, please.
Thank you, Massimo. It's a great pleasure to be able to present the rationale of the EMPOWER trial. These are my conflicts. So we all recognize a large unmet clinical need in heart failure, and that has to do with early intervention. Because we know that earlier on in the disease, LV dilatation, LV dysfunction predicts heart failure hospitalization and mortality, and the current guideline-triggered intervention referred to the more advanced stages of the disease. So the question really that we need to answer, can we intervene early in the disease process? And this is a disease process, this is a schematic. So basically you've got a patient with reduced ejection fraction, dilated LV, you've got some decompensation, and then the journey starts. The mitral valve is slightly affected. Then it gets worse after a couple of more decompensations. Medical therapy kicks in, and we know that when we intervene potentially at the late stage of the disease, we can change the outcome. But what happens if we intervene early? There's this area where mortality increases exponentially, and if we can get our intervention earlier on in the disease, we may be able to change this outcome. That's the concept. And we do have some evidence that this device, as simple as it is, as safe and as effective, can actually deliver. So thousands of patients have been treated up to date. There is a consistent reverse remodeling that we have observed in clinical trials. And of course, the label of earlier intervention, NYHA class 2, for example, or more, is there already. And this is the rationale. You catheterize the coronary sinus, is a maneuver that we've all been doing in the CRT business. You deliver this distal anchor, you cinch backwards, you reduce the perimeter of and the anteroposterior diameter of the annulus and the valve, and then you really produce significant reduction of mitral regurgitation. But not only that, you're pulling the base of the ventricle. And we have these 550 plus patients in the context of clinical trials, reduced FMR being a randomized sham-controlled trial that showed significant remodeling of the left ventricle. And of course, the EMPOWER trial is there now to make it more formal. So this is a trial that focuses exactly in that early stage of the disease, NYHA class 2 to 4, patients on stable dose of guideline-directed medical therapy, no CRT, and no other mitral intervention such as a TEER device in place. All we have to have is an ejection fraction less than 50%, diastolic diameter more than 57, and systolic less than 70, and any degree of mitral regurgitation could do. Severe, of course, and moderate is there, but even mild plus, provided the patient fits the criteria for heart failure. And the objective is to position the current therapy as the first interventional therapy for the treatment of heart failure in patients with secondary MR and dilated LV. This is the design of the trial. It's aiming for 300 randomized patients. This is a double-blind, sham-control trial, so there will be an interim analysis in the first 150 patients, 75 in each arm, until reaching the final 300 plus patients. And the primary endpoint by win ratio will be all-cause mortality, the need for alternative therapy such as heart transplant or LVAD, or other need of alternative therapy, mitral valve surgery or percutaneous therapy, need for heart failure hospitalization, and of course quality of life metrics, which are very important, such as KCCQ 6-minute walk. So this is a novel landmark trial that is aiming in a randomized, double-blind, sham-controlled fashion to position the device as a frontline therapy for heart failure patients at the early stage. This is the unmet clinical need that we're focusing. And it's important that we are aiming to treat all grades of mitral regurgitation. And, it's a broad inclusion criteria trial, so there will be not many patients that will be excluded. And it does allow in the time course of following the patients for alternative therapies. during this trial. Thank you very much for your attention. I'm happy to generate discussion and answer questions.
Any questions from the audience? Great talk. Thank you, Vlasis.
Thank you.
It's honestly, it's landmark trial. It's a sham-controlled trial, so I think it's the highest grade of trials we can conduct. So what you pointed out is that the focus should not be the reduction of the mitral regurgitation. The focus should be the improvement of heart failure. And therefore you conducted this trial with these endpoints. Is that right? And what do you expect more? Would you expect more that we achieve a longer life, or would you expect to achieve a better life for those patients?
I think both, really. In terms of mortality, I don't think that the trial, especially if you focus on the early stage of the disease where mortality is lower, is powered enough to show this. But I think if you can consistently demonstrate all the endpoints that they're hierarchically there, you might be able to demonstrate quality of life and, of course, potentially reduction of hospitalization. But it will be very interesting to see if there is an impact on these patients at this early stage of the disease. And the other important thing is achieve remodeling. Unfortunately, we do not have many options to achieve remodeling of a dilated LV, even when mitral regurgitation is not severe. CRT can achieve remodeling, but this is a different set of patients with white QRS complex. So here there's an opportunity to, on top of guideline-directed medical therapy, which is as optimum as it can be, and we're very good in treating heart failure with medication these days, achieve an additional remodeling on the LV at an earlier stage. I think this is wonderful, and we do not have options for that.
Because you mentioned the CRT system, even if we have a very good patient selection in CRT systems, we see non-responders. So even if you implant the CRT device, we see, okay, there's maybe a benefit in the QRS complex, but we do not see a clinical improvement. What do you expect for this CINCH device? So
really, this is a very safe and very easy to learn the procedure. So CRT can be challenging. I mean, I'm fortunate enough to be able to implant CRT devices, and we've all had our difficulties in finding the right vein and having a good threshold and not phrenic nerve, all the usual problems with CRT. Here, all you have to do is just size your coronary sinus, implant the device, and you immediately achieve a very good technical outcome. So it's simple, it's very safe, and the safety has been demonstrated in real life and various trials and registries. So the rationale is to show that, you can demonstrate the remodeling and the prognostic benefit in this population, and I think it's wonderful.
And without interfering with other cardiac structures, I think.
Absolutely.
Because we see a lot of patients, because we discussed it in advance. If you implant CRT leads, you can also interfere with the tricuspid valve, and this this decreases the heart failure symptoms.
That's correct.
Very often.
And you have the options open for the future, right?
Yeah.
If you want to do a TEER procedure, for example, later on, it's there. The valve is there for you.
We have a question. Why are patients with coronary sinus lead not included?
Well, that is a very interesting, and I'm pretty sure we'll touch upon that later on in the context. I think the rationale of getting into the trial is to keep it simple and make sure we do not risk any complications with the leads in place, not interfere with the great outcomes of an established therapy. And I think as a rationale, when you design a pivotal trial like that, it should be there. And I totally agree with that. Now, I know that there are implanters that are actually implanting Carillon in a very safe way with leads already in place. We've already established the option of implanting a CRT device with a Carillon already in place, and that's wonderful. So you don't lose the option of doing a CRT LV lead when you have a Carillon in place. But that's something to be discussed. I haven't done a single procedure like that, but I'm pretty sure others have done, and we'll look into that. I'm very interested to see.
Yes, we have in the next presentation some cases that we showed.
Yeah, that would be wonderful. I'm looking forward to that.
And there are not many trials with sham-controlled population in other device trials. So to be honest, you are one of the top enrollers in the trial as well. So how hard is it to enroll patients in such a hardly conducted trial?
Thank you for the question. It's really challenging. You need to be very open and clear with your communication to the patient that we're trying to do something safe, potentially effective, but not established yet. So you're going to be into a trial environment that it will be very safe for you, very heavily monitored, but in order for the trial to move on, you shouldn't really know what we did to you. We will do what is best for you. And I'm very surprised that this open communication with patients actually is working. Of course, we take every effort in the lab for the patient to be blinded, totally blinded, and also within our team to have people blinded to the outcomes, because the assessment, the heart failure assessment later on, the investigator who's doing that should not know what's going on. And this is a very tight schedule that we try to keep, and we've been so successful so far.
And patients are in conscious sedation, or how you treat the patient?
We do conscious sedation because it's easier to work. It takes some time for the randomization process to happen in the room, and also we make sure we totally blind the patient. Otherwise, we really have to blind the patient, put some earplugs and blindfolds. But we don't do that. We sedate them.
Okay. Other questions from the audience? We would like to engage you to the discussion as well. You see, we have experts here for a device which is really easy to use, and I think which will maybe improve also in this type of trial the heart failure symptoms of patients and the mortality maybe also.
I have a question. Waiting someone that to speak. I would like, what do you think? I think it's very important that you underline the fact that we are treating, please.
Sorry, Christian Ragler from Switzerland. I have a question. Can you use the CRT device after using this device?
Absolutely, yes. In fact, I mean, maybe some others are more experienced than me, but it may be even easier because you've got a marker where the coronary sinus is and you can cannulate a lot easier. Of course, experts don't have any issue with that, but it has happened and it's easy to do.
Massimo, your question.
Yeah, I would like, that is important to underline the first part of your presentation, that we are treating patients that are in the early phase of heart failure. I think that is the biggest message of this trial, and that could probably impact, if it's positive, guidelines, I think, because it's something new. What do you think of that?
Absolutely. That's why I started my presentation. There's a large unmet clinical need. Right now, we're focusing, if you look at the quad population, the RESHAPE HF2 population that I had the pleasure of participating, they're all more advanced in their disease stages. Low ejection fraction, severe MR, NYHA3 or ambulatory 4. Why not go earlier? We were definitely in a position conceptually to modify the disease process. And I think this is what Empower is all about.
Okay. Thank you.
Hans-Jörg, you have one more question maybe? The last one?
In the Empower trial, do you include also patients with preserved ejection fraction and heart failure, or only reduced ejection fraction?
The cutoff is ejection fraction of 50%. In fact, we have done a small study, but that was during the pandemic. The pandemic killed it, called the AFIRE trial with preserved ejection fraction above 50% and AF and atrial FMR. We put a few patients during the pandemic and that went very well, but it stopped, and maybe it's time to revisit the concept.
So thank you very much for this great presentation and discussion. Thank you.
Okay. We move to Peter Norberg. Please, Peter. And this is a very important point. Why indirect annuloplasty should be in your toolbox, in our toolbox, I could say. Please.
Thank you very much, and thank you very much for the opportunity to talk on this topic. So why is the topic so important? We already heard that it really affects a lot of patients, and if you look at the data from the World Health Organization, we can really appreciate that basically the majority of our patients we're seeing in cardiology, they are in fact at least to some degree affected by mitral secondary regurgitation. So every heart failure patient, every coronary artery patient, every AFib patient, they are all at least in part affected by the disease. And we already heard that what we would like to do is intervene early. And if you look at the guidelines, I think we all have looked into these, and I'm really personally a big fan of TEER, and we're doing a lot of those, and I guess many in the room are doing that. If we look at the guidelines, I think the guideline writers, they really did a great job improving our evidence and or bringing together the evidence and really pointing out that there is a good proportion of our patients which should be treated here. So we now, for the first time, have a 1A indication for TEER, but this is only for very specific patients with reduced ejection fraction, and also many specific these patients have to have. And I think this is well justified. And we've already seen that there is an alternative with the Carillon device, and I would like to show these images again, even though we have seen them. So if you see the valves in a patient like this, where the valves are really intact, and it is really a functional problem, so why would we want to touch these valves and maybe have problems in the future? So if you use the Carillon, I think the biggest advantage of that is that we really touch the more or less underlying problem, and we really stay away from the left atrium. So this is one of my patients. It's a 48-year-old female who was like in our center for more than a year, and you see on the left-hand side the baseline after more than a year treatment, and that was a familial dilated cardiomyopathy. So we decided to put the Carillon in. Here in the middle you see, actually you can appreciate the device here. And what we also can nicely appreciate in this patient, so it's not something which you see in every patient to this extent, because you always, of course, need some reduction in ejection fraction beforehand, but you can see nicely here that in many cases it's not only the regurgitation we're improving, but specifically we're seeing this reverse remodeling of the ventricle and also of the atrium, which probably is the reason why the patients improve so well over time. And we've seen a couple of trials in the past already, and we heard already that there is also ongoing trials where, again, I would like to point out that having really randomized sham controls double-blind trials is really a great thing, because this data is really something very specific to this therapy. And we've seen that reduction of MR can be achieved in the vast majority of patients, at least by 1 or 2 grades. We've also seen that the mitral regurgitation, the reduction goes along with reverse remodeling. This has also been shown in a couple of trial data already. And what is probably even more important is not that we're seeing there is like maybe the echoes looking a bit better. I think that's nice to see, but more important is, of course, how do the patient benefit from this? And we've seen in a couple of trials over the last years already that a New York Heart Association class improves, 6-minute walk test improves, and also KCCQ score shows improvement. We've also already touched safety, and I think safety is especially important if we think about early intervention. So if we want to do early interventions, that's really one of the key factors. Already pointed out, because we don't need to go into the left atrium, this is a big plus. Of course, there might also be some struggles with this device as well. So intervention is not always super easy 5-minute procedure, but it's super safe. I think that's one of the things which is important. For reasons also, we don't need any additional medication. And also in the long run, we don't have any struggles with the valves. So detachment of devices from the valves, or also mitral valve stenosis, is something which we do not see in these patients. We already touched CRT, because I think CRT is really something which is for many of our patients, for our heart failure patients with reduced ejection fraction, it really is a game changer. So we all have those patients where after CRT, maybe they don't need any more medication. So of course, they are all natural candidates for CRT. And this is one of the cases I would like to share with you where a patient who had a primary prophylactic ICD implantation before, not a CRT indication, and then developed left bundle branch block over time. He had this beforehand, we already had, because of mitral regurgitation, put a Carillon device in, which you can see here in place. And having done quite a lot of those cases, I can tell you, so if you want, in these cases, if they develop, you have a Carillon already in and they develop mitral CRT indication after, putting a lead in is really not a big issue. It's not more complicated with the Carillon device in. Yeah, so this is the result in this patient. The other way around is maybe a bit more complicated. I think we all know that if we have a patient where we already have a CRT in, many leads, maybe also other interventions these had before, it can be more complicated. We've done a couple of cases now over the years with now 21 patients who had the CRT before and where we thereafter, because of problems actually that the mitral regurgitation didn't really didn't benefit or didn't improve the way we wanted, or maybe in the long run they developed mitral regurgitation where we decided they needed a mitral intervention. And I think these patients usually, as you can see in this case, they really benefit. So we had only one case of 21 patients so far where for technical reasons we couldn't bring the device in and had to remove it, but we had no complications so far in these patients. And also we see the treatment effect here, so this is before and from 2023. Then we put the Carillon in here. What you can also nicely see with the Carillon in the cinching compared to before when they do the angiography only, and you can see that usually if you do that carefully there's no problem with the leads, and this is also what we so far at least found out when following up these patients. We had no problems with lead dysfunctions so far. I would like to conclude. So again, as already discussed, I think the Carillon is a minimally invasive, usually quick procedure which has a couple of specific benefits. So the fact that we don't need a TEE usually and only can do it like in deep sedation is a big plus, especially for elderly patients who are at high risk of delirium. The device can be fully recaptured until like the very last step is deploying it. So you can before check everything, and if you say, oh, we're not happy with whatever, you can take it out. The valve leaflets are not touched, and I think this is really important for early treatment, and in the long run and with the long-term data, I think this will come out very clearly that this is a big plus and it preserves all future treatment options. I'd like to discuss, if you like.
Peter, great talk, thank you. Are there questions already?
Yes, we have another question. Have you used Carillon as bridge to tear in large gap anatomy, and do you think there is a potential role there?
Absolutely, yeah. That's another of the, I think that's another very, very good opportunity to really use the device. So I think we all know these patients who are really, like when they are fully decompensated, maybe have additional problems, maybe on the intensive care, and really we can't really recompensate these patients. You can always do the TEER, and usually of course you see some improvement, but sometimes you see, or regularly you see a drop in the EF. Yeah, we just, those who've been in the previous talk, also it's for the right ventricle and the left ventricle. Of course, you see this this drop in the ejection fraction. This is, I think, something which so far I haven't seen in any of my Carillon patients, because we are doing, I think, a bit milder reduction, and we're not doing a stenosis. so this like immediate problems you sometimes see in the very severe mitral regurgitation with TEER. That's much nicer with the Caroline from my experience. So actually what we usually do in those patients, we first do the Caroline, and then if that's not enough, you can do the TEER after. So that's easy and no restrictions. So if the Caroline's in, usually the TEER after is much easier because the tension is so different. So you don't, and also from my experience, I don't have good data on that, but I think you have less stenosis after.
We have another question. Any long-term complication emerge around the coronary sinus?
Sorry again?
I repeat. Any long-term complication emerge around the coronary sinus?
Yeah, with the coronary, I think if you go into the coronary sinus, you have to, of course, appreciate that this is like a thin structure, and that you really need to adapt your technique, how to handle with that. I think in the long run, we'll have to see how maybe there might be some issues we don't know yet. But then again, if you know from the CRT patients and also from other interventions we are doing, usually I guess there is not something which we haven't detected yet. In the long run, we would see.
Peter, you are a very experienced interventional cardiologist. So usually you need an experienced stage to do TEER procedures. So now we have a Carilion device. You do not need a transseptal puncture. How many cases did you perform with Carilion before you felt really comfortable with it? So my question, in other words, is how many cases do you need to improve your outcome?
Yeah, I think the main issue is if you're doing CRT before, then it really is a super straightforward, easy procedure. All those who haven't done a CRT before, I think so. If it's the first intervention which you are doing where you're touching the coronary sinus, then you're sometimes, I think you need to adapt to some specifics, going in there, treating with different anatomies, same as we are doing this for left coronary.
So 5 to 10? What would
so
you
I
say?
think
5 to 10?
so for CRT guys, I think often like the first procedures can be like 15 minutes, perfect result, great. This can be also the case for someone never done this. I think if you're not doing or you haven't been doing CRT interventions before, then maybe like 5 cases, and thereafter I think you're confident.
Okay, perfect. Thank you.
We have Hans-Jörg Hippe that will show us a real-world experience, plus of 200 cases with carry-on patients treated. Please.
Thank you. These are my disclosures. Indeed, in our hospital, im Marienhospital in Witten, we collected the largest single-center cohort of Caroline patients worldwide. Currently, we evaluated 335 patients consecutively in a retrospective, non-randomized manner, and at baseline and at 3-month follow-up. Patients were collected over the last 4 years, and the patient's characteristics are mainly older patients, 83 years old, slightly higher proportion of females, slightly higher proportion of patients with reduced ejection fraction, and of course heart failure patients, symptomatic and moderate to severe secondary mitral regurgitation. The Caroline implantation is performed safely and without any intervention-related death and with a low complication rate. The outcome of the Carolan therapy shows a reduction in the mitral regurgitation grade. Most patients, over 90%, received MR grade 1 or 2. And the vena contracta is also reduced about 40%. And most important, the pulmonary artery pressure reduced by 10 to 15 millimeters of mercury, about 20%. The patient outcome improved significantly. Most patients are in NYHA class 1 or 2 after the procedure, and this is associated with a reduction in the BNP levels by nearly 50% after 3 months after the procedure. Of note, these benefits are consistent for both heart failure types, for a reduced ejection fraction as well as preserved ejection fraction. As a kind of mechanistic insight, we observed improvement in the diastolic filling of the left ventricle in terms of E over E prime ratio, which improved by 30% in nearly all patients, and other echo parameters of diastolic function also improved impressively. LV strain is shown here, left atrial strain and left atrial volume index indicating remodeling of the left atrium. We analyzed the impact of the Carolan therapy on the right heart. We observed improvement of the right ventricular contractility in terms of TAPSE by nearly 30%, and an improvement in tricuspid regurgitation grade, especially those with moderate TR. Those patients with severe TR respond limited to the therapy. One complication, so-called complication of the Carolan therapy is the compression of the circumflex artery. We analyzed 42 patients out of 350 Carolan patients with circumflex compression. In our cohort, we stented each patient with circumflex compression due to obvious criteria: stenosis grade greater than 75%, vessel diameter greater or equal to 2.5 millimeters, ECG changes, angina pectoris during the procedure, or of course left dominance. And after 12 months follow-up for most patients, we see no differences in clinical outcome in terms of NYHA grade, class, BNP levels, angina pectoris, or ECG changes. And we observed no major cardiac events in terms of MACE, including bleeding under the dual antithrombotic therapy. So we conclude that circumflex stenting in patients with the Carolan device is feasible and safe, and we consider the circumflex stenting as a procedural step of Carolan therapy rather than a complication that enables full angioplasty effect without adverse events for the patients. So let me conclude. The Carolan therapy shows a consistent patient's benefit in a real-world clinical environment. Over 300 patients have been treated with a high success rate and an excellent safety profile, with improved functional capacity in terms of NYHA class and BNP levels, with an enhancement of the diastolic function, including remodeling of the left atrium. In addition, we observed reverse remodeling of the right heart, including tricuspid regurgitation, and we analyzed circumflex stenting during the Carolan therapy and conclude it as a procedural step rather than a complication. Thank you for your attention.
And we have a question on this final conclusion. Can you comment on quite high number of left circumflex stenting in your cohort? Is it also a practice in other centers?
The stenting rate, the absolute number is relatively high because of the high number of patients. It's about 10% per patient per cohort, and our practice is to stent the patients with a relative low threshold to save the patient from complications and to enable the full effect of the Carolan device without compromising or recapture the device.
Maybe one comment, Vlasis, you also maybe one comment, but I think what we can see in your cohort, and thank you for the collection of this data in your center, great job, thank you for that. What we saw is that you had 2 or 3 pericardial effusions. And I think maybe you can point out, Hans-Jörg, when happens in what kind of procedures do this type of complications like pericardial effusion happen, so that you can maybe comment on your threshold of the circumflex stenting.
Each pericardial effusion occurred in the early stages of our program. In the first few weeks we are starting with the program, and so this is due to the learning curve, in my opinion, and one possible mechanism is the recapturing of the device, the movement in the CS with the device. This can be a possible mechanism for a coronary sinus injury, and with the low threshold of stenting, we haven't had recaptured any device in the last cases.
So it's a decision of balance. You want to avoid the complication of dissection and perforation, and therefore you do or perform an intervention in the circumflex which is feasible and very safe. You showed us that you control all your patients 12 months, 3 months at least, and you have no stent thrombosis, you have no complications with your circumflex stenting. So I think you are on the right side of the balance. And what do you think, Vlasis?
Actually, I need to congratulate you for this data. 0% death rate. I mean, you don't see that in any intervention. Obviously we say that Carolan intervention is safe, but 0% death rate is really amazing. And I really liked the concept of stenting in the circumflex. We do that in TAVI. We have a low left main, chimney stenting is there.
Absolutely.
Because the patient can go through the procedure. I personally haven't done it yet, and I needed to abort the procedure on a couple of patients, but because I was afraid that maybe stent will be crushed or dislocated, but obviously that's not the case. So I really like the concept that this is a step of the procedure as opposed to a complication. I don't know what your comments are on that.
None of our patients have been in hospital for a myocardial event, and STEMI or something like that.
We have question again for the stenting of that circumflex. Okay.
Yeah, sorry, just more of a comment. I understand the point about, we do this in TAVI, but we do TAVI for severe aortic stenosis. And this is something that we're doing ideally in patients who are, much, I guess, healthier. Their long-term outcome will still be better for a number of years. So I don't know that it's a direct comparison we can use.
Good point, but to give another point, if we do valve intervention in tricuspid regurgitation, we also accept that the patients are pacemaker dependent. You know what I mean? So this is a balance, and I think you do heart failure treatment. We do not do valve treatment. We do heart failure treatment. These are patients which are compromised in terms of healthiness and long-term outcome, and therefore I think it could be acceptable to balance these complications. And or if you call it a complication, it's about 8% of the cases. And maybe your threshold is very low, and maybe other thresholds are higher, and therefore we maybe just have to perform it in 5% of all the cases. But thank you very much for your comment. Thank you.
Thank you.
But I think heart failure is worth treated the same as aortic stenosis.
Yeah, coming back to Marek Grigren from Poznań, Poland. I'd like to come, I have done a few cases like that with Peter Nordberg. And thank you for helping me with these first procedures. I try to understand in which cases should I abort procedure because of a risk of circumflex occlusion, and in which cases I should go ahead, put a carillon device and then stent circumflex. In which circumstances you abort procedure, or are there no circumstances in which you abort the procedure because of a risk of circumflex occlusion, because you simply go ahead and stent?
Thank you very much. Good question.
In critical cases, we already prepared the circumflex with a guiding and a wire, and so we can, without any problems, stent the circumflex, and we don't avoid the implantation of the carillon device in any case, independent of the anatomy or anything.
Maybe a comment from Peter?
Yeah, maybe I think we have already heard that there is a couple of options you have to adapt, really, yeah. And I think you that's also where. So it's a question of in which direction you want to shift the risk, something. Yeah? So maybe to those who haven't done a procedure yet, so you have of course other options to adopt beforehand. So you could use a smaller anchor or a shorter device. So if you maybe have like a dominant CX with a very large marginal branch, you could opt for going not to the very last part, so the very distal part of the coronary sinus, to really like lower the risk of at least partial compression on the CX there. So you could also doing the cinching. So the way we usually do it, if I see that there is a pressure, too much pressure, then I just remove just a couple of millimeters, and then if there is some residual compression left, usually nothing happens. So I haven't had any infarction in all my cases. So I'm very restrictive, but if it's needed, I totally agree. Then it's a very good option, and also from our experience, stenting after, if you decide to do it, it's easy and safe.
And Peter, in your experience, how many stents you put in the circumflex?
Super rare.
Thank you.
Thank you very much for this brief comment on that. So 1 minute left. I would like to thank you, Massimo, to you, and thank to you guys for this excellent talks. And I think what we can sum up here is that we have a tool in our toolbox for interventions in heart failure, not in valve interventions, but in heart failure interventions. And I'm really curious about the results from the trial you showed us up. And I would say, if that happened, what we expect, we will have a guideline changing tool for heart failure interventions, Last but not least, I would like to say thank you to you all that you come over to here to listen to these talks, and I would like to say thank you very much to Cardiac Dimensions who supported this session, and therefore have a nice weekend, have a nice day, and have a nice Congress. Thank you very much.